Okay, welcome back, everyone. I hope everybody had a good break and got some caffeine and hydration. Really, we want to thank you again for your uh, really terrific engagement thus far in the course. We know this is a long time to dedicate to an event, but I hope you'll agree with Susanna and myself that these have really been tremendously outstanding and practical, up-to-date talks. So hopefully you're finding this as useful as I know Susanna and I are. This is now the part of the webinar where you get to hear Dr. Naggie and myself speak. So you can decide if that's a good thing or not, but it's my intense pleasure, and I know I'm looking forward to this talk tremendously, to introduce my co-moderator, Dr. Susanna Naggie. She is professor of medicine at Duke University School of Medicine. She also holds an appointment at the VA, the Durham Veterans Affairs Medical Center. She's really a tremendously outstanding and world-renowned clinical investigator with a focus on clinical trials in infectious diseases and translational research in HIV and liver disease, with a special focus on viral hepatitis. She's a standing member of the DHHS panel on antiretroviral guidelines for adults and adolescents and the CDC opportunistic infection guidelines. She also serves as Vice Dean for Translational Research and Director of the Duke Clinical Translational Sciences Institute. She's going to be speaking to us today specifically on hepatitis B as a sexually transmitted infection and what the updates are in that domain. Susanna, thanks so much for agreeing to speak to us today.
Well, thank you, Rafi, and thanks again for providing me the opportunity to be here to speak about hepatitis B co-infection. I think something that we all take care of quite a bit, but with long-acting injectables in particular, it's become, I think, some interesting clinical questions to address, and so that's how we will focus this. This is my disclosure slide regarding ineligible companies, and then also disclosures regarding other activities that I believe are relevant. So as I mentioned, in terms of learning objectives, the goal here really will be to ultimately focus on two key areas that I think we are all dealing with clinically currently in the setting of long-acting injectables, whether for treatment or prevention, which is that we are removing, likely in folks on therapy, hepatitis B active nucleotide analogs, and that can increase the risk of either reactivation or instant infection depending on the patient population that we're taking care of. So we're going to focus on what the various serologies are and goals of therapy, but also really talk about the preventative strategies for reactivation and instant infection as we continue into the LAI treatment realm. So I did want to start with just some epidemiology. And I think, everyone here is well aware of the global burden of viral hepatitis across the world, with over 250 million people infected with hepatitis B, close to 75 million with hepatitis C, which leads to really an enormous burden of disease and mortality, with hepatitis B being the leading cause of liver-related mortality globally. So this translates into some pretty significant numbers, as I mentioned, over 1 million people who die annually across the globe related to hepatitis B infection. And not surprisingly, the majority of people living with hepatitis B are unaware and not treated. And obviously, this is different in people with HIV because of engagement in care and recognition of the risk of co-infection. But still, in our patient population with HIV, a highly relevant disease. I put this up to maybe emphasize a few things regarding hepatitis B specifically. The first is to show you in the darkest part of this bar graph for each of the 4 of the 5 viral hepatitis is that hepatitis B can cause acute hepatitis. And I like to say to folks, I've spent my career taking care of people with hepatitis. And hepatitis B still scares me when it presents as an acute infection or as a reactivation, because it can result in fulminant hepatitis, which either will result in the need for liver transplant or death. And so that's really something for us to think about, particularly as we go through this talk. And then I think the other part to really emphasize is that hepatitis B as a virus is a carcinogen. So in and of itself, hepatitis B can cause hepatocellular carcinoma. Unlike hepatitis C, for example, which generally causes HCC in the setting of cirrhosis, that is not true for hepatitis B. And that is another reason that it contributes pretty substantially to global mortality. So I want to make a couple of points about hepatitis B that's relevant to the rest of the talk. And so I'm showing you this great graph of or a picture of the life cycle of the virus. I usually, as someone who takes care of patients with viruses, like to compare and contrast hepatitis B to several other viruses that we think of. So one is another virus that we all take care of is hepatitis C, or people with hepatitis C. And, if I put up a life cycle of hepatitis C, it's actually a very unique chronic virus in that it never enters the nucleus of the hepatocyte. And for that reason, I think it is an easier virus for us to treat and cure because there is no latency phase for hepatitis C. And with no latency phase, it also means there's no reactivation. But hepatitis B, like HIV, and probably even more relevant, I think, like herpes viruses, does have a latency reservoir. And therefore, even if someone does not have active infection, in the right setting can result in reactivation. And we'll talk about what those settings are and how that's relevant to people with HIV. But suffice it to say, I think it's an interesting comparison. So when we think about the evidence of latency phase in hepatitis B, and again, looking at the nucleus, it's the CCC DNA that is the transcript for reactivation. So unlike herpes or HIV, where the virus fully transcriptionally integrates into the host DNA, that is not true for hepatitis B. The transcriptionally competent DNA that goes on to form the actual virus particle or the surface antigen, which is one of the tests that we use to determine active infection, is actually off of the CCC DNA. So to remember, CCC DNA is the latent reservoir and the site of reactivation. And then the other point that I want to make that's highly relevant is where do the nucleotide analogs or NRTIs in this case, so whether that's 3TC, FTC, tenofovir, or in the case of a non-NRTI, so not active against HIV, but active against hepatitis B and entecavir, where do those act on the life cycle? It's here at number 5, which is inside of the immature nucleocapsid. It's the RNA reverse transcription to DNA, which is why with this polymerase, with these polymerase inhibitors, it works against both HIV and hepatitis B. So I do have some audience response questions here in my talk. So remember that that this will pop up as we read the question so that you can answer. So, and this is actually a real patient in my clinic that I've been taking care of for many years, but it always helps to walk through a real case. So this is a 52-year-old man who presented to my clinic with chronic hepatitis B infection. He had been previously treated, stopped therapy, and now we were initiating him on treatment with TDF-FTC. He was followed in clinic regularly, and I repeated his hepatitis B surface antigen every year, which is the recommendation for people with chronic hepatitis B infection to monitor them for hepatitis B surface antigen clearance at least annually. So what should his serologic testing show? So should he, and you can see the different options here, positive surface antigen, antibody, and core, negative surface antigen, negative antibody, positive core, positive surface antigen, negative surface antibody, positive core, or a negative surface antigen and positive surface antibody and positive core. So what does it look like to have chronic infection? So go ahead and vote. We'll give it a few seconds. I imagine you all have been voting, so we'll see what the results show now. The majority of you said that he should have a positive surface antigen, which is correct, and a positive core antibody, which is correct, because just like syphilis, once you've been infected with hepatitis B, you will always have a positive core antibody. And that is the evidence, remember, of exposure and of risk for reactivation. And because he has not developed a surface antibody, which is negative here, he has not cleared his surface antigen. So that is the correct answer. Now a follow-up, why did I put this patient on TDF-FTC when the recommendation for therapy in someone with chronic hepatitis B without HIV, which is the case here, is for either entecavir or a tenofovir prodrug like TDF or TAF? And I think you all know the answer to that. It is because this patient is also at risk of infection from HIV, and so he is also on PrEP. So we are doing two things at once by treating his hepatitis B and keeping him on 2-drug therapy for HIV PrEP. So I'm going to move really quickly through a couple of basic slides regarding the serologies for hepatitis B. And maybe really quickly recognizing that chronic hepatitis B is very, very common. Well, the ability to clear hepatitis B depends on how old you are and the health of your immune system or the development of your immune system when you're exposed. So as we know with vertical transmission in neonates and young children, the risk of going on to chronic hepatitis B is very, very high because their immune systems are not fully developed. Once someone has a fully developed and healthy immune system in even late adolescence and early adulthood, in fact, adults and humans clear this infection very, very well. I like to say that's why we have a highly active vaccination. But people with HIV who have HIV first and then get exposed to hepatitis B have lower clearance rates or higher chronic infection. So I wanted to give a couple of kind of take-home points as it relates to serologies. So surface antigen is our test for whether someone has active infection. E-antigen is a test that we actually use really to understand replication capacity. So positive e-antigen means you expect very high DNA levels, and e-antigen negative status means you expect much lower DNA levels. And this is actually relevant when you think about, for example, risk of developing hepatocellular carcinoma, because the higher your DNA, the higher your risk of hepatocellular carcinoma. Core antibody, as I mentioned, like a syphilis IgG, is positive for life once you've been exposed. So it tells you if someone's been exposed, and it also is the singular test that tells you whether or not someone is at risk for reactivation. So if you had to choose one, that would be the answer to choose. And then surface antibody tells you whether or not someone has developed immunity, which, as we will talk about later, can wane in certain populations. And that immunity could be from prior exposure, or it could be from vaccination. So the approved therapies or recommended therapies currently in people with hepatitis B are both nucleotide analogs, entecavir or a tenofovir-based prodrug. We have had no development in new hepatitis B therapies for a very, very long time. And obviously in people with HIV, the recommendation is to have at least 2 active drugs. So you'd have one of these recommended therapies and then either FTC or 3TC, which are no longer recommended for the primary treatment of hepatitis B because of low barriers to resistance. And for people with HIV hepatitis B, as folks are probably well aware, our primary focus is on normalizing their ALT and AST, so showing no longer signs of liver injury, and then also getting that Hep B DNA down to an undetectable state, which is really critical. As I mentioned, that really nice data that's led by Nina Kim et al. Suggested that even a viral load over 200, a Hep B DNA over 200, can increase someone's risk of HCC, or hepatocellular carcinoma. And so it's really important to focus on getting that DNA suppressed. There's also an interest in achieving what we call functional cure. And functional cure, as you can see here, normalizes ALT, has undetectable hepatitis B DNA, and actually has an undetectable hepatitis B surface antigen. So essentially getting to that natural clearance that we talked about earlier, if at all possible. And the truth is, with treatments, we do not get very far with functional cure. It is an area of intense focus currently with new therapies, but right now the best that we can do is to suppress that DNA and decrease the liver injury. Now, interestingly, people with HIV hepatitis B, and there are now multiple reports of this, if someone is diagnosed with HIV hepatitis B and they initiate antiretroviral therapy, they actually have a higher surface antigen conversion rate than someone who doesn't have HIV. There is a very clear association with CD4 count. So the lower your CD4 count, the more chance that you actually clear your surface antigen as you have immune reconstitution. And I suspect that this is that group, as I showed you on the prior slide, of the 21% of people with HIV who do not go on to, who do not clear the infection. And it's likely those folks who probably would have cleared infection if they did not have HIV, but in the setting of the immune dysfunction in HIV, they are less likely to clear it. And that immune reconstitution provides them that opportunity to go on clear the infection. I think we have a lot to learn from how to achieve clearance in other populations by understanding this immunologic phenomenon in people with HIV and hepatitis B. So back to the patient. So this patient's been followed in my clinic for a very long time. And as I mentioned, I'm checking his surface antigen and his surface antibody with some regularity, not necessarily always annually, but knowing that there's a chance of clearance in all patients, I do follow this clinically in my folks. So he has been on now tenofovir and FTC for a while. He clearly hasn't aged though, so that's interesting. His serologies, as I mentioned, were surface antigen positive and core antibody positive, as you all got, and surface antibody negative, but now his surface antibody has turned positive. So what do you expect his repeat serologic test to show? So we'll go ahead and pop up the for voting, so we can do two things at once. But do you now expect his surface antigen to remain positive or to clear? We know his surface antibody is positive, and what do you expect to happen with his core antibody in the setting of his surface antibody turning positive? So we'll give you a few seconds to vote. And we will show those results to see what you all think in terms of what his serologic status should look like now. So because he has developed a surface antibody, he should clear his surface antigen. So you all nailed this one. 74% of you say, yes, his core antibody should remain positive for life. But now that he's developed that surface antibody, he should clear his surface antigen. And that's exactly right. So he goes into this state of having evidence, right, of immunity in the setting of prior exposure. And that's how we know that from his surface antibody and his core antibody. And so that's a good state for him to be in. That would mean he actually no longer needs hepatitis B therapy, but he remains on treatment because he remains on pre-exposure prophylaxis for HIV. So now we're going to talk about prevention, and then we're going to bring this all together on why this is important in this patient. So many of you may know that there's been some pretty significant movement over the past few years in new vaccines for hepatitis B. Historically, as this figure shows you, we know that people with HIV had significantly lower response rates to standard hepatitis B vaccination, where the majority of people without HIV had close to 100% seroconversion or serologic response rates. People with HIV at best would maybe hit 50 to 70%. And I have listed here the standard vaccines that we used historically. But several years ago, a vaccine called Heplisab-B was approved by the FDA, not in people with HIV. And this is an adjuvanted vaccine that adds a TLR9 agonist to increase the immune response to the vaccination. So all of these vaccines expose the patient to the hepatitis B surface antigen at various doses. But this TLR9 agonist was proposed to potentially increase response rates. It was really critical to have data in people with hepatitis B, in people with HIV for this vaccine, which again, in people without HIV is approved as a 2-dose series at 0 and 4 weeks. So many of you may have seen the results of the Beehive study. This has been presented now at CROI twice, and both arms of this study have been published. So the two groups, Group A, were looking at people with HIV and non-response to conventional vaccine. And they compared this to the standard Ingerix or aluminum-based 3-shot series. They wanted to compare both the 2-shot, which is approved in people without HIV, and the 3-shot because right, we're trying to understand what the right answer is here is, do you need 3 shots in people with HIV, or can you use the same 2-shot series? in what you would consider to be the most difficult to vaccinate, which are people who have previously failed prior vaccination. And then they did a smaller group, a single arm with a 3-shot series of the adjuvanted vaccine and people who had never been vaccinated before, just to develop some evidence. The primary outcomes for this were seroprotective response, which is standard for vaccine studies, with an anti-hepatitis B or a hepatitis B surface antibody greater than or equal to 10. But they also looked at quantification to really understand the robustness of the serologic or seroprotective response with these different formulations and doses. So we're going to focus on results that have now been published, which is their primary outcome at 28 days. So essentially 4 weeks from the 3rd shot, or obviously for the 2-shot much longer. But then also at CROI, they also presented longer term 72-week follow-up, which I think is actually really important to see. So looking at where these data currently exist, as I mentioned, the single arm vaccine naive group was published in CID, and JAMA published their much larger arm in folks who had previously failed vaccination. So what I'm showing you here is Group B. So remember, these are folks who have never been vaccinated before. And what I'm showing you here is a comparison of that Group B, who, remember, they got 3 doses, 0, 4, and 24 weeks, compared to Group A, who you would technically say may have been a harder to vaccinate group because they'd already failed a prior vaccination series. But what you can see is, frankly, these curves converge very quickly by week 4. And in fact, there was no difference between the vaccine naive group and the group who received 3 shots of the adjuvanted vaccine who had previously failed. So these are really high response rates, as you can see, which is very good news for our patients. Looking at Group A, remember there were 3 arms. This is the one that did compare to the prior standard of care, which was the aluminum-based or Ingerix vaccine, which is a 20 microgram dose of Hep B surface antigen. And again, in the kind of peach bars or lines and in the teal lines, you're seeing the different doses, both the 2-shot in the peach and in the green, the 3-shot of the new adjuvanted vaccine. And the take home here is to tell you that between the 2 and the 3-shot series at 24 weeks, there is no difference at the end. And you can see that these are clearly superior to the prior standard of care. But you do begin to see, even between the 2 and the 3-shot series, while they remain very, very high in terms of that end of treatment response, once we get out to the longer follow-up period of 72 weeks, you do begin to see that these lines are changing, and they are getting further and further apart. So that means you are beginning to have some drop-off in the 3-dose series, and you certainly see drop-off in the aluminum vaccine of people who are now dropping below that titer of 10, where we would recommend either a booster or revaccination, because in a patient population with HIV, we have concerns that there's now no longer signs of protection. So take away from this is that whether a 2-shot or a 3-shot, this vaccine is superior to the prior standard of care. But that there may be some difference in terms of the longevity of that protection, even within 72 weeks. And this bar graph shows you something very, very similar, which is if you focus on the gray being a loss of protection, you can see very quickly the prior standard of care loses protection even within 72 weeks. But you can begin to see this as well in the 2-shot as well. So, I'll talk about the guidelines in terms of what the recommendations are, but I think what we do see is that we have a new highly effective vaccine that hopefully will be soon added to the approval for people with HIV, but that the robustness of the response in terms of titers does appear to be higher in people who receive 3 versus 2 shots. The other focus for prevention is to remember that HIV active antiretroviral therapy, so TDF containing and probably 3TC and FTC containing regimens, are prevention for hepatitis B. So if we remove those either as part of a oral antiretroviral therapy or as part of an oral PrEP, we are going to lose that protection in these folks. And so this is actually a study showing you that exact thing, which is in a large population of people, and actually men with HIV and men who have sex with men in HIV. What you see here is in the blue bar are folks who were on active antiretroviral therapy that did not include 3TC, FTC, or tenofovir-based regimen. In red, you have people who had activity, so 3TC or FTC, but not tenofovir. And in green was folks who were on tenofovir. And the bottom line is that, not surprisingly, tenofovir is one of the recommended drugs for hepatitis B. You have a very low risk of developing new hepatitis B infection. But in those who were not on active hepatitis B antiretroviral therapy, and who were at risk, which means they were not vaccinated or did not have an antibody, did develop incident hepatitis B infection in this setting. And this is true if you look at HIV prep as prep for hepatitis B. So this similarly is in a group of folks who are at high risk for HIV and at risk for hepatitis B, which means they did not have hepatitis B surface antibody. These are folks who were being followed in the clinic, and actually in Japan, they were high risk. Some of them were not on PrEP. Some of them were on PrEP, either daily use or event driven. And you can see here that those who are not on PrEP in the Kaplan-Meier curve just continue to have a risk of developing incident HBV infection. And again, just really emphasizing that these drugs are adequate for prevention for hepatitis B. So if you are going to take someone off an oral therapy, then you need to ensure that they are vaccinated or that you're working on full vaccination to be able to prevent hepatitis B infection if you're taking them off of these therapies. And again, just emphasizing this point, you can see here in the next graph that HBV incidence and HIV incidence really kind of overlaps here in terms of looking at risk. And meanwhile, STI incidence, which PrEP does not act against, you can see high rates, which means these are high-risk folks who are not getting HIV or hepatitis B at the same rates as the other bacterial infections. So to bring this all together, I want to now talk about where we are in terms of clinical guidelines and thinking about hepatitis B prevention and what to do when you're switching folks off of oral therapies to injectable therapies. And so I'm not going to focus as much on the primary vaccination. Updated guidelines for opportunistic infections now recommends this adjuvanted vaccine as a 2-shot series. This does not reflect the data from the 72 weeks, but ultimately I think 2 shots is great. And you're either going to monitor people's titers and booster them when their titer drops below 10, which is the recommendation for people with HIV, or potentially consider doing a 3rd shot. For revaccination in people whose titers drop, which we know they do, as we saw, the recommendation is either 2 or 3. And this is going to be really relevant when we talk about those patients who have isolated core antibody that you are withdrawing active hepatitis B therapies on. So maybe to get to that, right? So you have a patient, and we know a lot of our patients, about a third of our patients with HIV will have an isolated hepatitis B core antibody. So remember, that means that they have been previously exposed, and it means that they are at risk of reactivation. And the recommendation is do the best you can to booster them to get an amnestic response and develop a surface antibody. The issue is with the prior vaccinations, we don't have data for this in people now with the adjuvanted vaccine, but with the prior vaccines, we know that in isolated core antibody in people with HIV, the amnestic response with a single booster was somewhere between 24 to 46%, depending on which study you see. And we also can see in the box below, amnestic response, yes, with a single booster, 46%. But even over less than a 2-year period, that drops to about 19%. So these are not long-lasting amnestic responses. If you, in fact, vaccinate people that are isolated core with a full 3-shot series, you're much more likely to get to a long-lived response. And thus, that is likely the best approach to these isolated core antibody folks as you are going into potentially withdrawing active hepatitis B therapies as part of their core antibody, as part of their antiretroviral therapy. So really, another last audience response question is, in this patient, over time, his antibodies continue to change, where he did lose his surface antigen, but not surprisingly, he also lost his surface antibody. So now he's isolated core. And he did not respond to a booster vaccine. And he comes in and now he is asking about long-acting injectables for PrEP. So the questions to you all is, what do you say? Yes, we can switch you over to long-acting injectable PrEP, nothing to worry about. Yes, but there is something we have to worry about. No, you have chronic hepatitis B infection, you have to stay on active hep B therapy. Or you had hepatitis B infection and you need to stay on active hepatitis B therapy. So which is it? So we will see what responses you all have provided. But I would say the answer is yes, you can go on long-acting injectables, but we do have to worry about that isolated core antibody. So let's see if we can get that result. Yes, great. You guys are excellent. So that's exactly the right answer. And that's what that is what we wanted to address when we put out these recent guideline changes with DHHS. And this was really to focus primarily on raising awareness of the risk of either incident infection, as we talked about, or reactivation in the setting of removal of these therapies. So yes, we have to worry about this. How are we going to manage it? The way that I think about this is Hep B reactivation occurs in people who have been previously exposed or have, well, let's just focus on people who've been previously exposed. And usually we think about this in terms of the risk of the provocation. So is it a low risk situation? Is it an intermediate risk situation? Or is it a high risk situation? Many times, what we deal with clinically, usually, right, is the patient who's coming in, their isolated core antibody, they have lymphoma, they're going to get rituximab, which is really high risk, and they all get empiric therapy for prevention with a nucleotide analog therapy. So the question is the removal of Hep B active therapy in the setting of isolated core antibody for people with HIV low risk, intermediate risk, or high risk? And the answer is we don't know, really. We have very little data. And the largest study is actually the study I'm showing you here, which was actually a oral abstract at ID Week, but has not been published. And the overall rate that they saw of people with HIV and isolated core who had removal of Hep B active antiretroviral therapy was somewhere around 1.5%. Depending on serologic patterns, it could be as high as 20 or as low as 0.4. So what we made a recommendation for in the guidelines was to say this is likely a low risk provocation, maybe intermediate risk. And in either case, the recommendations from guidelines is that you can monitor these patients, make sure that you are not seeing an increase in hepatitis B DNA, or more importantly, an increase in ALT, in which case you would need to restart Hep B active therapy. And so with that, we will maybe optimize time for questions, and I will stop sharing.
Thanks, Susanna. That was really terrific and so great to have someone who's actually part of the guidelines body talking to us about this so we can get all of our pressing clinical questions answered, right? Because when you layer difficult diagnostic to interpret diagnostic tests with complex clinical scenarios, you get lots of questions. So thank you. That was wonderful. So we've got a bunch of questions for you in the Q&A. So let's start with sort of perhaps the easiest one, because I think I know the answer, but you'll tell us. If someone needs both Hep A and Hep B vaccines, would you recommend Twinrix for simplicity and compliance, or would you use Heplislav based on the Beehive data you just showed us, and the Hep A vaccine separately? And let me throw on top of that, would you change your answer if it was someone with HIV versus not?
That is a great question. So I can tell you what I do in my clinic, and I will go back and say, what did I do before? And before we had Heplisav, I actually gave a double dose of hepatitis B in Jerix, and so I was giving double doses of Twinrix anyway. So now I do one dose of Heplisav and I do Hep A separately because I really want to optimize that hepatitis B response. And the question is, what about in people without HIV? And I would say that the data is the data. I mean, a lot of the patients I take care of who don't have HIV have diabetes or other comorbidities where we know that response is lower. So Heplisav is my go-to regardless of HIV status.
And based on Kristen's data from Beehive that she presented this year at CROI, are you routinely doing 3 for everyone with HIV?
You know what? That data changed my practice. I was doing 2 before that, but I think what my takeaway from that is that you can do one of 2 things. 3 is going to get you higher levels, and then they're going to trail off over a longer period of time. So you can either, I get them 2, and if they're in my clinic regularly, I am starting to do a 3-shot series based on that data. Otherwise, you can do 2 and then follow titers over time and then booster. But my guess is you're boostering sooner if you did 2 versus if you did 3. Yeah.
Okay, so since you brought up the titer question, what are you doing in terms of monitoring hepatitis B surface antibody titers? Let's say people with HIV, let's put it in that context. Are how often?
Yeah. Yeah. So I don't follow titers in people without HIV. So there's that. So
Okay.
but in patients with HIV, I do follow titers. And as I like to say, if you ask 10 people who do this for a living, you may get different answers. So you're getting one answer from me, which is the recommendation actually in the guidelines is to follow annual titers. I do not. I follow titers based on what they are. So if I get a titer of 15, I'm definitely repeating that a year later because my guess is they're going to be less than 10 a year later, and I'm going to be boostering them. But if they're 150, I'm probably not going to check them again for 2 years or 2 or 3 years. And I also do that based on what their risk is, right? So I don't necessarily always follow the guidelines exactly. I let the titer guide me.
I love that. I'm a big fan of acknowledging that guidelines are exactly that, right? They're guidelines. They're not, the letter of the law in all cases. So thank you. That's really great. You talk about this a little bit, but could you talk about in your clinical practice, isolated core antibody, how you use DNA to monitor?
Hmm. Again, 10 people, different answers, right? So there's occult hepatitis B, and that is when you have someone who has a negative surface antigen, a positive core. So we know that they have that cccDNA in there, and you can check a DNA, and there's going to be a certain percentage of people who will have a detectable DNA. My issue with that is I'm not sure what I'm going to do about it because I'm probably not going to start them on on nucleotide analog therapy. So I am not a DNA monitoring person unless it's someone, as I mentioned, that is going to get rituximab or chemo, or we are actively withdrawing therapy and we're in that period of 3 to 6 months where we're monitoring. That's when I'm doing DNA testing.
Perfect. Really helpful. Again, something I think I know what you're going to say, but I can't wait to see if I'm correct about this. So, somebody who is on Descovy or Truvada, well, let me rephrase. Sorry, TAF FTC or TDF FTC PrEP. No, sorry, I lied. That's part of their ART regimen. We're talking about somebody with HIV.
Okay.
So, do you recommend um, hepatitis B vaccine in someone on
Yeah.
an ART regimen that contains that if they're isolated core antibody, but negative surface antibody?
Yeah, it's
That's
a great question, right? So I think the question is, if they're on therapy and it can prevent their hepatitis B, then how eager are you to pursue getting them to convert their surface antibody back? And here's what I would say: we know that, as I showed you that data, that these therapies can prevent hepatitis B, but there is no better prevention than a positive surface antibody. So even in folks who are on active Hep B therapy for PrEP, I am pretty aggressive about trying to get their hepatitis B surface antibody converted by boostering or completing a full vaccine series. And as we saw from that data, you can get those folks at a rate that's somewhere close to 70 to 80% after full vaccine. Yeah.
I love the use of the term to booster as a verb. Boostering. I've not heard that before, but now that will become part of my lexicon. So thank you for that. Could you talk a little bit more about the amnestic response? And it sounds to me like you're saying, give me antibody documented on a laboratory assay. You're not willing to bank on protection that if somebody is re-exposed, that even if antibody has
Right.
quantitatively waned, the amnestic response on exposure is going to be enough. Could you
Absolutely. It's a
discuss?
really important point. And this is a big difference between someone with HIV or another at-risk group, like people with diabetes, et cetera, versus someone who is a completely immunocompetent host. it's different, right? In an immunocompetent host, we actually don't follow titers once they've shown response, and we don't booster them because we do believe that with exposure, their memory will come back and be fully protective. But we have data that says that if you are a host who does not have a fully competent immune system, someone with HIV, diabetes, elderly, we have evidence that that is not true. So we don't have confidence in that memory in someone whose antibodies waned. Yeah.
Love it. So we are out of time, but maybe we do one more quick rapid fire question. People with HIV, isolated core, their surface antibodies repeatedly less than 10. You've boosted them from here to boostering them from here to next Wednesday. You've Heplislaved them.
Oof.
After three attempts, what do you bother anymore, or you just sort of throw your hands up and give up?
No, I think there are those folks right now. We in the Heplisab error, I don't think we have the data to know. But if they've gone through a vaccine series of Heplisab and still failed, I think my education to them, and I'd just be really cognizant of the fact that they are, at risk of reactivation, and we need to monitor them for sure. Yeah.
Okay.
All right.
Terrific. Thank you, Susanna. That was really wonderful. That so much rich, good information there. Thank you.